Bismillah Rahman Rahim. Good evening, everyone. Very much esteemed colleagues and participants. Really appreciate, as usual, you have joined us today for this webinar. It's my pleasure to welcome all of you for this insightful webinar session organized by Saudi Society for Medical Education Riyadh office. And topic is really very much interesting and timely. Clinical simulation in medical education, especially talking about recent trends. Today, we are gathered to explore the evolving landscape of clinical simulation, an essential component in modern medical education. Simulation is something which is not really new, but definitely we are going to talk something new, latest. We are going to talk something about virtual reality, augmented reality, some touch to AI, recently within clinical simulation, and to examine how these innovative and transforming medical training is being done in medical education. We are very much honored to have Mr. Anan Al-Badawi, a highly respected expert in the field, to lead this discussion and share his expertise on enhancing skills, critical thinking, and patient safety through simulation-based education. Very warm welcome, Mr. Anan Al-Badawi.
Mm.
He is simulation educator at Atkan Clinical Simulation and Innovation Center, Hamad Medical Corporation, Qatar. He holds master's degree in medical education from University of Dundee and diploma in clinical simulation from Lebanese American University and bachelor degree in nursing sciences. Anan has varied professional background, having worked for 5 years in nursing and 12 years in pre-hospital care setting. He has been a speaker on many conferences, Emmy conferences, symposium, and workshops related to healthcare and medical education. Anan is actively involved in research and serves as a reviewer for different journal articles. His area of interest is pre-hospital emergency care, CPD, curriculum design, research, and simulation-based education. I highly encourage all of you to engage actively in this session. Let's explore more and let's see that what is new in simulation. I shall be moderating this session along with Dr. Ali, and questions will be taken by end of this session. So very warm welcome and over to you, Dr. Anand.
Okay. Assalamu alaikum. Thank you, Dr. Shazia, for the invite to this webinar. It's a great pleasure actually to be here and present my topic, clinical simulation and medical education, the recent trends. So before we start, I would like to disclose that I have no conflict of interest regarding the content of this presentation. Today we are going to cover four themes. The first theme is about the role of simulation in enhancing patient safety, the role of simulation in enhancing clinical competencies, and also improving skills acquisition. And finally, we'll get touch onto the integration of AI, virtual reality, and augmented reality in clinical simulations. So this is about me. Thank you for the introduction, Dr. Shazia. The first theme to start about is the role of simulation enhancing patient safety. Uh, the patient safety is the cornerstone of our speak today, which is refers to all policies and procedures that aims to enhance the safe delivery of the care to our patients. Anything that can be done to enhance the patient outcomes, that's what we call it, the patient safety. The patient safety was not a matter of concern, in fact, until the release of the Institute of Medicine report, which was in the 1999. This is one of the remarkable publication in the 20th century that talks or highlights or rings the alarm about this patient safety concerns. Many horrible figures that has been raised in that report. As you can see, around 98,000 Americans dies from preventable medical errors every year, and about the financial cost of medical errors, which was around like 17 to 29 billion dollars every year. This is only in the US. However, The report itself suggested many recommendations to enhance the patient safety concerns, such as the creation of specific agencies, mandatory reporting of safety events, as well as the continuous education. Which one of them involved the simulation medical education? So how big is the problem? As you can see here, if you look at these horrible statistics, so the first landmark study was done in Harvard in 1984, which shows that around 180,000 patients dies yearly because of medical errors. Then the IOM report came in 1999, speaks about around 98,000 of patients dies annually because of the medical errors. As you can see, the rest of studies which shows horrible numbers, especially the one in 2013. So despite the advancement in technology, despite the advancements in medicine, but the preventable death was still high. Around 5 billion people dies annually because of preventable medical preventable dies because of preventable death in hospitals. Okay, so these are another statistics. Basically, was in 2016, which shows around 21% of the American get exposure to medical errors. The cost that the US pays yearly due to medical errors, the number of patients, and also we can see that the last one is the most important figure here to find out actually, which shows that around 50% of the medical error was involved whom? The newly graduated nurses, those who have less than 1 year of experience at patient care. Okay, just remember this figure. We're gonna continue our discussion and we'll see the role actually of simulation-based education in enhancing patient safety regarding this concern. So what were the root causes? The root causes, according to the GCI, falls in the following criteria. The first one is the poor communication. Second is the human factor, such as burnout, distraction, poor leadership skills, poor assessment, poor continuum of care. So all of the leading factors that you can see here are related to whom? It's related to the human being. In fact, it's related to the human being. And that's why there is a belief that the creation of simulation-based learning activities that focuses on the patient safety concerns may enhance the patient safety and also may reduce the number of preventable deaths every year. So what is simulation-based education? I like actually the definition of David Kappa regarding the simulation, which is a technique. So simulation, it's a technique. It's a training approach. It's not a technology. That replaces real patient encounter with artificial models, live actors, or virtual reality patients in an interactive fashion. So why simulation? Why simulation means what I'm trying to say, why do we introduce simulation as a training approach that enhances the patient safety? If you look at the cone of learning, the cone of learning was invented by Edgar Dall in 1969, which shows how people retain the information, how people learn actually. So after 2 weeks, if you return to any learner that who reads something, he or she will be able to recall only 10% of what they have read. If you look at the bottom of the pyramid, the learner can retain around 90% of what they practice. So this is the concept of simulation-based education, is the experiential learning, learning by doing. Reason number two. So the common teaching methodology in the academia is heavily relied or was heavily relied on lectures and the presentation. And that creates a significant discrepancy between what we have in the academia and on the clinical settings. So the simulation formulate as a bridge in between the academia and the clinical settings. And there are many, many approaches to simulation-based education that starts from the see one, do one, teach one approach, which is outdated. We will come to that later on, to the creation of the one of the modern approaches to the simulation, which is the simulation-based master learning. Reason number two, it has been evident in some of the literatures, some of the universities, they proved that the simulation can substitute 50% of the encounter with patients. Okay, because in simulation, we can simulate anything. We can simulate simple cases, and we can simulate high risk, low frequent cases, which we can't actually see always in the hospital, which we can't always have the chance to practice them in the hospitals. So when to use simulation? So simulation can be used for multiple purposes. We can use it for teaching and learning. We can use it for assessment and also for research. Simulation can be used to introduce a new technology or device, to introduce a new guidelines, or to introduce a new process, such as blood donation, such as a blood transfer, getting a blood from the blood bank, for example, getting the patient to the PCI procedure. Then, so you can test guidelines, you can test the clinical space. Yeah, you can test also the workflow, for example, in the outpatient clinic to see the waiting time and so on. Also, it can be used to identify the barrier in achieving specific targets. For example, our target for the door-to-needle in stroke patients is around 4 hours, but we can see that the process takes around 6 hours or 5 hours. Then there should be a problem. So let's simulate it to find out what are the gaps in achieving that protocol. Also, we use simulation to enhance the communication skills, the leadership skills, and also the teamwork skills. So how the simulation enhances the patient safety? Uh, the simulation, as I said earlier, it forms a bridge that that covers, or it's a bridge in between the knowledge or in the academia and the clinical practice. Simulation provides us with a safe, controlled environment where we can do mistakes, even if we kill the mannequin, that should be fine. This is a risk-free environment. We learn from our mistakes through discussions, through debriefing, through the repeated practice, through the deliberative practice, and so on. Definitely, and it was proved that being engaged in simulation enhances the competency and enhances the confidence also in many disciplines, including nursing, medicine, paramedicine, and so on. The more that you get the chance to practice something, the more that you have the confidence to do the skill in front of an actual patient. Similarly, for the team training, uh, we can have an excellent staff in the hospital from different disciplines. We can have excellent nurses, we can have excellent physicians. But does that really means that we have excellent team? Definitely no. That's why the team-based training is something important, and especially in situ, especially in the hospital, we let nurses, physicians, physiotherapists, all of them working together in the same process in order to enhance the communication, in order to enhance all the human factors, which will result in, by the end, with improving the patient safety. Also, the simulation can enhance the safe patient care by identification of system failures. It can be used also for mitigation of rare events. Okay, that's what we call it, simulation for modeling. Modeling is the prediction of the worst. So we can simulate an event and see what is the percentage of having this event to happen. So we try our level best to prevent it. Again, the simulation is a psychologically safe learning environment. There is no blame and shame environment. It is expected to make mistakes, and that's fine. We are there to learn, and the people usually learn from their mistakes. And it's an evidence-based practice that prove its efficiency in many of the literatures. So the anatomy of a simulation experience, that any simulation experience starts usually with the pre-briefing, which is the introductory phase where we introduce the scenario, where we introduce the learning environment, equipment, expectations, learning objectives, then the scenario itself, and after the scenario, we have the debriefing session. In the debriefing session, it's a reflective conversation where we analyze and discuss the learner performance, identifying the gaps in knowledge and skills, and abstract conceptualization, taking the learning points to the clinical arena. So what are the types of simulators? I'm not referring here to the type of simulations, but to the simulators. Simulators are the equipment used or the device used in the simulation. The first one is called Task Trainer. Task Trainer is a body part or body region that can be used only for what? For learning isolated skills. There is no need to buy full technology mannequin with thousands of dollars just only to practice skills. So the task trainers are basically used to practice technical skills, simulated patient or standardized patients, those who are well-trained individuals that can be utilized for simulation activity. We can utilize them actually for history taking, for communication skills, and also the physical examination. Um, you might hear different terminology, like standardized patient. We refer to that terminology when we are looking for standardization of the process, such as summative assessment or high-stake assessment. Simulated patient, when the assessment or the learning experience is only for learning purposes. So the SP here has like some sort of flexibility in dealing with the learner. Simulated participant related to any person. So the individual here can play the role of a physician or maybe family member. So then full body mannequin. The full body mannequin, it can be a high-tech mannequin or a mannequin without any technology. Hybrid simulation. So the hybrid simulation is the combination of two simulators together. For example, we can use a wearable task trainer with SP to practice the procedural skills and communication skills, like the wearable IVR. Or we can use the SP and mannequin to practice the communication and pelvic examination. Because the pelvic is one of the sensitive area and not all SPs actually agree to be touched on the pelvic. In fact, this is another discussion like the invasive or evasive procedure in SP education. So the extended reality, this will be discussed in a separated chapter at the end of the presentation, inshallah. But it's a type of simulators. Supporting evidence. So there are lots of evidence that on the literature that proves the efficiency of simulation-based education in enhancing the patient outcomes. Enhancing patient outcomes refers to what? It could be reducing the mortality rate, reducing the morbidity rate, the reduction of infection rates in CVP infection. It could be the reduction of infection rate in urinary catheter insertion, or it could be IV insertion, and something like that. Okay, so this is one of the recent literature that included 27 articles, and the outcomes, as you can see, the simulation, so overall, resulted in the improvement of competence and confidence for the learners. It improves the knowledge and compliance with infection control measures, and also it decreases the infection rate, and also it decreases the health costs as well. So that was about the first theme of our talk today. The next theme is the simulation for clinical competency assessment. Sorry, I saw one of the candidates raise his hand. The questions, inshallah, will be at the end of the presentation. Thank you so much. So simulation for competency assessment. In fact, the best method to assess the competency of a healthcare practitioner is when you see him or her practicing with actual patients. But this is not always possible due to safety concerns. This may cause harm to the patients. This could be unethical actually to let a learner just to jump in a critical situation and treat a patient in that case. The diversity of cases, it's not always possible to see high risk, low frequent cases, okay? And also it's time consuming. So that's why the idea came from the Accreditation Council for Graduate Medical Education is to consider simulation-based education as a method of assessing staff competencies. So this is one of the recent systematic reviews that shows also that the simulation-based education can be a good or a reliable methodology to assess the staff competency. In what? In low frequent, high risk, low frequent skills. So for assessing the competency, we have the Miller's Pyramid. The Miller's Pyramid framework is widely used in the academia. It has 4 levels for the nose and the nose how levels. These are basically concerned about the assessment of knowledge level. For the shows how level, it is concerned about the assessment of clinical competencies in a simulated environment. And the last level, which is the DAS, is concerned about the assessment of competencies with actual patients. So how about let's dig deeper in the shows how level. We can assess the clinical competencies in the simulated learning environment in the following. We can, through a SPEES, assess the history-taking skills, communication and physical examination skills. Through task trainers and hybrid simulations, we can assess the procedural skills. Okay, we can assess also use the animal models or screen-based or virtual reality simulation. OSCE. OSCE is an educational approach which introduced in 1975 in the University of Dundee. It's an effective approach actually to assess the clinical competences. And also it relies on the Miller's Pyramid level. So in OSCE, as you can see here on the picture, you can see some of the candidates are doing knowledge assessment on computer or paper-based. This is to assess the nose and the nose how levels. And some other candidates are engaged with SPs and task trainers to practice technical skills. So usually in OSCEs, we have a set of learning objectives, we have a set of clinical competences to be assessed, and also we have different approach in how to assess each competency, which is restricted by time. The most important part of the OSCE is the feedback that every learner will take to the clinical arena. Okay. So where they can use this feedback to enhance their performance with actual patients. So, and this is one of the recent studies that compared the OSCE against the traditional clinical methods to evaluate the clinical competency. And the systematic reviews that shows that the OSCE is more credible assessment format to evaluate the clinical competencies of undergraduate nursing students compared to traditional methods. So you can take this example. This is a systematic review, which is a robust evidence. And you can search more in the literature actually to find more examples. Another concept is the simulation-based mastery learning. This is one of the modern approaches in simulation-based education, which is a model relies on the deliberate practice approach. Okay, we are going to talk later on about the deliberate practice. Just to try to think about this example, how many minutes would you take actually to change a tire of your car? But roughly for a normal person, that it may take like 15 to 20 minutes. You can imagine the McLaren team in 2012, they were able to change the 4 tires in the Formula One pit stop within 2.5 seconds. So how did they reach that level of performance? What do you think? So this is the result of what? This is the result of setting objectives, setting also precise performance measures, which is the time, also setting competencies, and then also setting what? Increase of difficulty or going for higher level objectives. This is the concept of the simulation-based mastery learning. Now people takes the skill as an automatic skill. They don't have to think that much when they apply or when they change the tire here. So that's basically the approach of the mastery learning. First of all, take the assessment of take the baseline assessment of your candidates. See where are they at this moment or at this level, and then you can set certain objectives with certain performance measures for each level. Once you make sure that all the learners achieve the objectives regardless of the time, then you can move to the next part, which is more difficult, and then the most difficult part, until they reach the mastery level. So this is the concept of the simulation-based mastery learning. Uh, Jeffrey Barsuk. Jeffrey Barsuk is a professor in medicine and medical education in Northwestern University. In fact, he and his team did really a great job, an amazing job in the integration of simulation-based mastery learning in many domains. You can just type his name and find in the literature. So I'm sharing with you here three of the studies where Dr. Jeffrey and his team use the simulation-based mastery learning to reduce the complication during the central line insertion and also the peripheral line insertion and also during the performance of paracentesis procedure at bedside. Another study here that shows the enhancement of the staff performance during a code or during ACLS procedure, and also the enhancement of the patient outcomes when they use the simulation-based mastery learning in their training. So regarding the clinical competencies, maybe we speak a little bit about the individual, but how about the teams? Uh, Remember our discussion earlier, we said that people usually dies because of the poor communication. So this is the concept of the simulation-based interprofessional education, where we gather learners from different perspectives, from nursing, from medicine, from respiratory therapists, anesthesia. We call them all together and they learn about, they learn from, and they learn with each other. So this is one of the effective approach that initially will identify the gaps in communication in between the teams, identification of the latent safety threats, which results actually in the enhancement of the patient care. And the more that if we are in a hospital environment, the more we work together, the more we become good to each other, and also the more we communicate well, actually, and we speak also the same language, which will reflect at the end to the patient safety. So this is the end of our second theme. Now we are heading to the next theme, which is the simulation for enhanced skills acquisition and the critical thinking. So let's talk about initially about the domains of learning. So when we talk about the domains of learning, we are referring to three. We are referring to the cognitive domain, which is concerned about the knowledge acquisition, the affective domain, which is concerned about the attitude or the reaction of the learner towards an activity, the change of the thinking or the behavior towards a certain situation at the end of any learning process. And finally is the psychomotor domain, okay, which is concerned about the skills acquisition. So what do we mean by psychomotor skills? So if we break it down, in fact, there are two words. Psycho is related to the procedural rules. Procedural rules mean first we start with hand washing, then identification of the patient, preparing equipment, and so on. Motor is the learning of a new muscular movement. That's why it's called psychomotor skills. So when we learn a new skill, actually, we are learning both the procedural rule and also a new muscular movement. So what's our goal when we learn a skill? Initially, for novice learners, let's take an example of of a learner that who's novice. So when the learner is novice, at the beginning, he is unaware that he is unaware about the skill. Once he or she take the initiative to do the skill, they will start to realize saying that, yes, I am unaware about how this skill should be performed. And then with the continuous practice, the learner will say, yes, I know how to do the skill, but I need some effort actually to do it. I need to spend some cognitive thoughts while I'm doing the skill. And finally, the skill will become automatic. The learner doesn't have to think that much when he or she performs the skill. So he will be unconsciously competent. That's what we are trying to, or that's what we should actually try to do when we teach our staff any of the skills. So the phases of skills development are three. The cognitive phase, this is actually for novices when they try to learn the new concept of the skill, when they try to perform the skill, making mistakes. Then, with the frequent and continued practice, the learner will move to the associative phase when they start to have an understanding of how the skill should be performed. And finally, the skill will be autonomous or automatic skill. So that's what we are also trying to reach here. Depth taxonomy. Depth taxonomy is a well-known framework of teaching psychomotor skills. Which says the following. For teaching a skill, first we start with imitation or having an instructor doing the demonstration of the skills, then giving the chance to the learner to practice the skill, which is the manipulation, giving him or her feedback, precisation, where the learner has the ability to perform the skill with limited number of mistakes. Articulation refers to the learner who can perform multiple skills together, maybe during situation or during complex scenario. The naturalization is the ability of the learner to perform the skills without having that much cognitive load so that he or can she free himself to find another aspect of the patient care. This is the concept of Dave's taxonomy. So what are the techniques of teaching psychomotor skills in the literature? So there are many approaches or techniques for teaching psychomotor skills. The first one is the see one, do one, teach one. This is an outdated approach, but we'll speak a little about it. That's an approach where initially the learners see how the skill being performed, and then he or she will take the initiative to do the skill and then teach the next candidate how to do it. This is an outdated framework because it's actually there are many safety concerns highlighted. The learner who see the skill and do the skill one time is not actually safe to teach the skill for the subsequent candidates. Whole part whole, it's a three phases. On the first phase, the instructor will demonstrate the skill with just only headlines about each step. Now I'm going to do this and this and this. And then upon completing the first part, the instructor will explain part by part how the skill should be performed, and finally will demonstrate the skill without any interruption. Peyton is one of the commonly used method where the instructor demonstrates the skill three times. The first one is without interruption. The second time is with explanation. The third time with learner guidance. And then finally, the learner will have the chance to practice the skills. But usually, this approach is performed one-to-one between the instructor and learner, but many people are using it for multiple learners nowadays. George and Dotis five steps methods is another approach where initially the learner will have an idea about the importance of the skill, why this skill is important. And then the three steps approach of demonstration, like what we discussed earlier in the Peyton, silent demonstration. This will provide the mental picture to the learner on how the skill should be performed. And then deconstruction of the skill. This is to allow for questions about techniques, sequence of actions, and then guided demonstration. This is to ensure understanding, and then continuous practice until achieving the proficiency. However, the recent evidence shows the following, that the Peyton and George and Dotis has limited evidence of their efficiency in teaching complex skills. For simple skills, yes, that's fine, but for the complex skills, there is limited evidence that they are effective approaches. Wow. So this is the last framework. This is the most recent framework for teaching clinical skills, which is the learn, see, practice, prove, do, and maintain framework. In fact, this is a recent framework. This is the only framework as of now which is concerned about the three things: the development of the skill, the assessment of the skill, and also the retention of the skill. Three things which was not available actually in the previous ones. In fact, I developed one course recently, and I'm teaching this course right now in our center. If anyone from Saudi Arabia or abroad would like to attend that course, you can drop me an email, message me on LinkedIn, and you are most welcome actually to attend the course for free. You are most welcome. So the first stage is about the learn or acquire the cognitive knowledge about the skill. This should be done before the practical time through didactic sessions or online sessions or whatever. And then the C approach is concerned about the demonstration using the three steps as what we have described earlier. The practice time is the application of the deliberate practice approach with feedback from the instructor. Prove is the summative assessment where the learner has to prove his or her competency to do the skill. So now the do and maintain are concerned about the clinical practice. Do is the performance of the procedure on real patient, but under observation or under supervision. And then finally is the maintain. So to prevent the skill decay, there should be a frequent practice from time to time on these skills to prevent the skills decay and enhance the retention. So deliberate practice, we have mentioned a lot about the deliberate practice, and these are the attributes of deliberate practice. The deliberate practice is a motivated learner who set a specific learning objectives and the precise performance measures, who practice repetitively with formative feedback from his tutor with increasing difficulty in order for what? To enhance the performance of something. This is the concept of deliberate practice. So this is the end of our third theme. Sorry if I'm rushing. I tried to compile many topics. I'm trying just to cover the most actually. The last theme in our webinar will be talking about the integration of artificial intelligence, extended reality in clinical simulation. In fact, as we know about the AI, it invaded our life actually in almost everywhere, in the entertainment, in finance, in banking, social media, in medicine, and also in education. And one of the areas that where AI actually was involved is in the simulation-based medical education. So how the AI was introduced in simulation-based medical education. First is through the extended reality, and later we will come to discuss the extended reality where we have the virtual patients. Okay, AI is also used to analyze the performance of a candidate and providing a specific feedback on the areas of improvement. AI is used currently for personalized learning. Remember that each learner has his or her own attributes, has his level, certain level, learning style. So the simulation activity can be customized based on the actual level of the candidates. Uh, and also, AI can be used for writing scenario scripts like using the chat GPT, like using of Gemini, Copilot. Um, in fact, if we have time, I can share with you one of the recent studies that I shared in the last conference, where some of the researchers actually used the ChatGPT to write simulation scripts. They identified the strength of the ChatGPT, the gaps, and they suggested the strategies on how to enhance your writing of simulation scripts using the large language models. So speaking of the extended reality, we always hear about the concept of VR, 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 VR. But in fact, the biggest umbrella that contains all the realities is called extended reality. So what falls under the extended reality? We have the augmented reality, we have the virtual reality, and we have the mixed reality. These are the three domains, and we are going to take them one by one. So when to use virtual environment? Virtual environment used when we want to simulate a difficult patient situation. It could be a geriatric patient, obese patient, pregnant, pediatric patient. We use it also, we want to share the resources amongst each other. If we are looking for standardized experience for everyone, introduction of difficult concepts, difficult materials, and also if we are looking for the repetition and also feedback. Advantages of virtual environments, it can enhance the clinical decision making. You can role play actually many different attributes of patients. It helps in knowledge integration, in team communication, and also it enhances the learning process. And also it's a customized learning experience where we can have a set of increasing difficulty of experiences where we can test and challenge the learner in different levels. So you remember what happened in 2020 when COVID came, there was a closure of the academic institutions and there was a huge demand on increasing the number of staff, especially on the critical areas. So there was limited accessibility to training resources. There was a limited inability to perform face-to-face simulation activities. And from that time, there was an increase in what? In the on the virtual reality simulations, okay, and also distance simulations. So there is a growing body of the literature. You can just, I just provide an example, like I just type virtual reality simulation in PubMed, and you can see the increased amount of the literature over the past 5 years. So the first type of extended reality to discuss is the desktop virtual reality. The desktop virtual reality refers to a computer or iPad or a cell phone with an installed platform where the learner can navigate a case. The learner can practice their decision-making skills, critical thinking skills. You can practice also some of the skills, but there is a limitation actually in the skills performance. You cannot actually perform the actual skills here, but also you can practice the history taking and physical examination skills. Next is the immersive virtual reality. So in the immersive virtual reality, by wearing a headset that covers the eyes and the ears, you are now totally away of the real world and have 360 of virtual environment. So the immersive virtual reality has many applications in the literature. We can use it for history taking, physical examination, for diagnosing patients, for formulation of treatment plans, for learning technical skills, for also communication skills. We can use it also for drills and also test of your leadership skills. Like in ACLS, you can like give instruction to the avatars here, like or to the virtual participants here. Okay, you take the blood pressure, you perform compressions, you start bagging. Also, you can practice the decision-making skills and the clinical reasoning skills. You can practice the de-escalation skills. Also, it's an excellent approach for safety assessment. We can simulate a virtual environment and we can identify where are the latent safety threats in a place. We can use it also for wound care. It can be used also for dental care, for disaster management. Also, we can use it for clinical imaging, different ones, CT scan, MRI, and so on. For geriatrics, for obstetrics, for pediatrics, virtual SPs. Actually, now there is a bit of change from the actual SPs or the human being SPs towards the virtual SPs. This is one of the recent trends, actually, because you know that with the human SPs, there are some of the challenges. One is the consistency of the performance of the SP. Second is the potential bias, okay, which may result actually, especially in the competency assessment, with less valid or reliable scores. But now there is a move now towards the integration of virtual SPs and assessment of competencies. We can use also virtual reality for surgeries, for EMS cases. We can simulate anything like an RTA scene, earthquake where they need to respond, explosion cases, and so on. So, in fact, I tried to search for an evidence regarding the effectiveness of virtual reality, but I found hundreds of evidence actually. Hundreds of articles were written about the virtual reality. We know that some of them are actually with, some of them are against, some of them are natural. So I just picked some of the articles to show you here. So one of these articles were talking about comparison in between the head test, or sorry, the immersive virtual environment and desktop virtual environment in teaching skills. And in fact, there was no significant difference in between both technologies. The second study proved that the chest compressions using virtual reality was effective, was perceived as an effective method than the traditional method for learning CPR skills. In that study, actually, they tried to put something heavy over the patient shoulder, over the participant shoulders, and perform in the virtual environment, and it was perceived as more effective than the traditional one. Third, it was evident that the virtual reality improves the competence of medical students, respiratory assessment skills over the traditional methods of learning. So these are another three articles. So where they assist actually in nursing. All of them actually are systematic reviews and meta-analysis papers. And the overall findings from these articles were the following, that the virtual environment was effective in enhancing the knowledge of the participants. They were also effective in enhancing the psychomotor performance among the nurses. And also they were effective in cognitive outcomes, such as the theoretical knowledge and medication administration, aseptic technique, and the management of respiratory distress and blood transfusion. And the key takeaways from all of these articles were the following. Point number one, the virtual reality was effective in enhancing the theoretical learning. It was effective in enhancing the learner attention to the activity itself. It was effective in enhancing the communication skills and also the complex teaching the complex concepts. The interactivity, yes, it was engaging and it was perceived as an interactive learning. And it was also a good approach actually for collaborative learning for multiple learners from different domains. Augmented reality is a bit different from the virtual reality. So in the augmented reality, we have an overlay of digital content over the actual world. So, and it can be accessed through either a cell phone or through the headset. So once you wear the headset, you will be able to see a digital content, but you can see also the real world. And in fact, there are many applications of the augmented reality in simulation. In fact, it wasn't found to replace the real environment, but more of enhancing the real environment. So it is heavily used for surgery, for physicians who would like to learn more about the anatomical structure that cannot be found by naked eyes, okay, and for learning some of the technical skills, including needles, injections, laparoscopic procedures, intubation, and so on. The mixed reality. The mixed reality involves what? The mixed reality involves both the virtual environment and also the real environment. How can this be achieved? If you can see the pictures of these simulators, the screens presents the virtual environment, but we are actually doing the training using an actual environment. This will enhance the realism of the experience. It will enhance it in the following. First of all, with haptic feedback that the simulator can provide you. Plus, you can personalize the experience based on the learner level. It provides you with the specific feedback on how did you perform. Since it's a surgical procedure, it can provide you with feedback on how did you perform inside the knee, for example. How many tendons that you hit? What is the percentage of damage? What is the percentage of occurrence of safety events if you perform the same? And it provides you with feedback on how to enhance your performance. It contains also some models from beginner to advanced on how to approach these kind of simulators. In fact, I'm more fan actually of this approach actually to learn more. Yeah. So this is about the mixed reality. Again, there are tons of articles that talks about mixed reality and augmented reality. I tried my level best to collect some of the review articles that talks about the augmented reality or the extended reality in healthcare simulation. This is another article on how to design a mixed reality simulation. Another one is about the role of extended reality in healthcare education. This is another systematic review also about all of them. And this is another one actually that compared all of these methodology with standard training methods. So the research focus on augmented reality and mixed reality were on the following, based on the analysis of these academic papers which I presented a while ago. The most focus was on the anatomy and anesthesia. Next was for radiology and ophthalmology. The next for cardiology and dermatology. Next is for family and forensic medicine. And finally is the gastroenterology and neurology. These were the research focus area on AR and MR. But for the summary, and when analyzing all of these articles, let's talk about the impact of each one of them. In fact, for the knowledge acquisition, maybe I have presented earlier for the nursing perspective using AR, there was a significant increase of the knowledge or the cognitive retention. But here, when analyzing the papers, we found some discrepancies. Some papers suggested that yes, the extended reality was effective in the knowledge retention. Some paper didn't find any significant difference. It was similar to another simulation methodology or another educational approaches. There was a significant enhancement in the skills retention or skills performance. It was perceived as realistic and engaging, and was also for acceptability and usability. Yes, it was highly acceptable. But in fact, I just had one concern here regarding most of the papers that were represented, that it was mostly about the learner perception towards the activity. It's more of subjective data. Maybe there is limited evidence using RCT, for example, or using objective measures. That is another topic that I will talk about in the last slide, inshallah. So we spoke a lot actually about the advantages. We spoke a lot about also the relevant use of extended reality. But what are the challenges actually of extended reality? In fact, regarding the cost and equipment, at the initial stage, yes, it's costly and it's a great and a huge investment. And actually, until now, there is a dilemma in the literature. Is it really cost effective or not? Because some people would say, yes, at the beginning, it's costly effective, it costs a lot, but for the long run, you can save money. It's cost effective. So there is still a dilemma about that point, which requires further investigation. Another challenge is the learner curve. Since we are not dealing with actual instruments, this may hinder the effective tool utilization. Another one, it may cause an impairment of human contact. Remember that most of the activities are done individually or personalized activities. So, which is undermine actually, or let us say, limited the exposure to other learners, which is one of the concepts actually of the simulation-based education. We want people to talk and learn from and about each other. Uh, the bulky headsets, I tried them actually, they are heavy. So it was not comfortable actually for some of the learners. It's not comfort like all the time. And compatibility issues. So sometimes the software will get outdated, you need update. Maybe the software is not compatible with the internet, the speed that you have, internet connection, connectivity issues, glitches, software, and all of these factors. So these are the challenges of the extended reality. So finally is the research direction. So the research direction, so upon searching on the literature in many of the journals, in fact, each journal has their own direction, has their own interest of research priorities. That's what I was able to summarize for this slide. The research priorities are the following. First is the innovation in theory and methodology. As I said earlier, most of the researches about the integration of extended reality are more of subjective data, assessing perceptions. So there is a huge demand on the inclusion of objective measures, such as RCT and so on. There is a need for more studies on the impact of patients on learning outcomes. Maybe I have presented some of the literatures from Barsock and another example, but still there is a need for more research on the impact of simulation on patient outcomes. There is a need also for more simulation for equity, diversity, and inclusion. Okay, because remember, and especially in Gulf countries, that it's a mixture of people from different cultures, from different domains, and the simulation is the best environment where we can gather everyone to break that barrier between different population, different cultures. Okay, so there is a need for more studies to study that area. Faculty development and the quality assurance. Simulation, as you said, Dr. Shazia, is not a relatively new, but it's been widely used. And now there is a huge demand on the high technology, such as high fidelity simulators, AI simulators. Nowadays, actually, we have two examples from one simulator called Alex, and there is another simulator from GoMart. Uh, these provided with AI technology where you can have a conversation with the mannequin and the mannequin is able to reply back to you. Okay, so there is a need for the faculty to be familiar with the use of technology, and also there is a need to for performance measure, to set of competencies for simulation educators. There is a need also in the literature for more articles on the design and the implementation of simulation best practices and how the simulation is integrated in the healthcare systems. IPE simulation is still understudied. There is also a need for more studies to investigate the actual impact of the IPE simulations on the actual patient outcomes. And also we want to investigate the impact of simulation on the long term for the skills development. So this is the end of the presentation. Thank you so much for listening and apologize. I was rushing a lot. I tried my level best to cover everything from each theme of the webinar.
Yeah.
So I welcome any question, Dr. Shazia.
Thank you so much, Anand, for this such an enlightening and detailed presentation, I would say. I
Mm,
think you touched upon all aspects of simulation along with details of extended realities, which we were expecting that what is new over here in simulation. Really appreciated. Lot of evidences you provided. Probably you meet a lot of above our expectations going
no
through
problem.
literature. Thank you so much. Great
Sure,
effort.
no problem.
So we are happy to take questions. Feel free to write your questions in chat box here rather than using Q&A. And I can see that there are few hands raised. Um, Probably hand raised is from Sesame webinar. Yes, I can allow you to
Okay.
ask question. Uh, Dr. Ali, can you try to speak?
Okay.
Yeah, we can
Thank you,
hear
Dr. Anan. Thank you very much. I really enjoyed and learned a lot. It's quite interesting subject, and
Thanks a lot.
I'm sure in the future it's gonna be overwhelming. I would like to tell me or your view regarding from medical education point of view, the difference is there should be a difference between simulation-based learning and simulation-based assessment. Are they are the same or they are completely different concept?
Okay, thank you very much for your question, Dr. Ali. They are quite different concept. The simulation-based learning is an activity that aims at learning a new concept, where the competences or the grading is not part of the process. But the simulation-based assessment is mainly based for competency assessment, where the assessment component is there, where the competency checklists are there, and the result will be pass or not pass. This is the only difference between both of them. It's the same activity, but this one is for learning and providing feedback, and the other one for competency assessment. Yes. Hope this answers your question.
Yeah, indeed, it did. Thank you.
Sure.
Thank you. So I would invite question from participants. If you have any question, please feel free to write in chat box or raise your hand. Meanwhile, I shall be waiting. Anand, my question is that I'm sure that when we talk about simulation based education, there are a lot of challenges, as you showed in a couple of slides in your presentation. Faculty development is one of the biggest challenge. I would like to hear your experience at your institution that how you are tackling faculty development challenge, how you think that we can train faculty members, especially in undergrad medical education.
Okay, thanks, Dr. Shadi, for the question. In fact, the best methodology to enhance the faculty competences in handling simulation session is the continuous education. Number one, the approach which we are using in our simulation center, that we are developing an evidence-based simulation activities, okay? And all of these simulation activities are purely hands-on. For example, I said earlier about the learn, see, practice, do, maintain a protocol for teaching psychomotor skills. In fact, I found lack of knowledge for some of the educators on how to teach a skill, because the skills lab is not a place for lecturing. It's a place where people should practice. Okay, so from that point, we develop that course, we teach that course, where each instructor or each candidate has to prepare his or her skill and come and teach it in front of each one and receive feedback on your performance as an educator. This is the best way of learning how to teach a skill. Similarly, for the other courses, we are actually teaching for now 7 courses. One is the pre-briefing, where the participants actually has to take a scenario and write a script of pre-briefing and say it in front of others. Another one is the scenario design, where people has to come for 4 hours to sit as a group, to sit learning needs assessment, to set learning objectives and receive feedback. Was these objectives actually smart or not? Was the objectives covers that needs or not? Was the simulation modality is appropriate for these objectives or not? So it's again hands-on experience. Another course which we are delivering is the evaluation. Evaluation in simulation is a big word. We have formative, we have summative, we have high stakes evaluation, we have the evaluation of the instructor, him or herself, the evaluation of the activity. So all forms of simulation evaluation are introduced in that activity in a form of hands-on. Another activity which we are handling also is the facilitation. It's a 2 days program where people on the first lane come and design their simulation activities, and then on the second day, they facilitate the entire simulation and receive feedback from A to Z, from pre-briefing until the debriefing. There is a specific course also about debriefing that we are facilitating, where the educators have to come and watch a video and debrief it to others and receive feedback on their debriefing skills. So basically, Moulaj also is another course. Basically, these are the courses. And inshallah, I'm planning to develop one more course to deliver in the next year, is about the application of simulation-based masterly learning. I want to jump not only from the sim center to the hospitals or to the clinical practice area, and also teach people there how to teach the skill on real patient and how to retain the skill actually. Yep. So that's for the faculty development. We believe the continuous education, and most importantly, it should not be a presentation wise, but more of hands-on. They need to try it. They need to try it and receive feedback. This is
Yeah,
one of the best ways to improve.
really impressive work what you are doing to develop your faculty. I think that is much needed, especially kind of mini workshops or courses. That's really amazing.
Yeah,
I can't see any
thanks.
questions. I hope that participants, they are not feeling any difficulty to write questions, because chat is open for everyone.
Yep.
And I don't see any hand raised till now. Allow me to ask one more question. I'm very much
Sure.
curious to know that which
Mm.
kind of augmented reality tool you are using at your institution, especially for undergrad medical teaching program? Because when we talk about using virtual reality in simulation, there is a debate that this is good, this is not good. Desktop based kind of virtual reality
Mm.
platforms, they are good, or with headset they are good. So I have no idea what is your experience and what you guys will recommend us based on your experience at Qatar.
Okay. Maybe I cannot provide the direct and full answer about that because your question is about the undergraduate medical students. In fact, our simulation center is a clinical based, it's a hospital-based simulation center. So I have some connection with Qatar University and the University of Doha. Uh, they actually have their own simulation centers. They started to bring the high fidelity mannequins, and they are on the way actually to bring the technology of AR and VR and MR to their places. So, but they sometimes visited us for some of the procedures, actually, for some of the things. Yep. So just to provide like a precise answer for your question, Dr. Shazia, um, to the best of my knowledge, I'm not quite sure if it's implemented in the undergrad as of now.
All right,
Yes.
because currently in UK, in our practices, when I am a member of simulation committee, we are using Oxford Medical Simulation as well as Body Swaps, which is having many AI features because we want to enhance soft skills among our medical students, communication skills, breaking bad news. So they are talking through these headsets to these patients, and these patients are so quick and efficient to understand the context of conversation that it's really amazing when it is
Mm,
about feedback or assessment. So we are
yes.
trying these kind of tools, but I
Mm.
don't know that which kind of tools are being utilized in Middle East or in Saudi Arabia. Anyways, things are coming
Uh,
so quickly. Technology is advancing so quickly.
but, Dr. Shazali, what I advise, and mashallah, you have the more experience than me. But think about the technology that can can fit for multiple learners actually.
Yeah,
You know that most of the extended reality simulators are personalized only for one learner. But when you talk about undergrad, we're speaking about hundreds of patients who wants to have the chance of a practice. So maybe this is one of the biggest things that you have to keep in mind is the collaborative learning, where learners or like maximum number of learners can practice at the same time.
do agree. Absolutely
Yeah.
agree. So there are no more questions. We are happy
Sure.
towards the end of this webinar. Anything else, Dr. Ali, you want to add or?
Thank you very much. I would like to
You know,
express my appreciation to Anan. It was really very, very informative and lots of informations. I wish we will see him again in the
Inshallah, sure.
futures.
No problem. No problem. It's my
Uh,
pleasure, Dr. Ali. Thank you so
Thank,
much. Thanks a lot.
thank
Before
you
we
very
end
much.
Thanks.
this webinar, Dr. Ali, you want to share webinar of next?
Yes, and it's really you guys can have a see the screen now, and
Yes,
we would like to extend our network. So Dr. Anan, feel free, please, to help us to extend our newly born webinars in medical education. So this
Mm,
is our next webinar. Is going to be about enhancing clinical assessments and somebody's going to do the critical roles of rubrics in health professions educations.
mhm.
So inshallah, we will be more than happy to see you on the 19th of November at 8 o'clock.
as
Okay, sure.
participant. Yeah.
Sure, inshallah. It's my great pleasure actually.
Yeah.
Inshallah, I'll be there.
So thank you so
Thank you
much
very
for
much.
this session. Thank you, Anand, for your acceptance for this SESME webinar. Thank you, all participants, and have a
Thanks
great
a lot.
day. Bye-bye.
Thanks. Likewise. Thank you. Bye bye.
Allah Hafiz.